first Lunch and Learn series. And we had said the last time, it was the last call, but this talk was really a gift for us. Some of you know that we have the funding through HRSA, which is a sister agency for NIH, needed for, or the funding is used for identifying gaps in genetic services. So this is one of the activities we had started with great success, and the reason it's taken a little bit longer with technology is because there are other sites which are connecting through here who will be watching this. And we are also taping this to be available to fellows and for teaching purposes on our website at CERP Newborn Screening. So it was a team effort, and I feel very fortunate to have somebody like Dr. Verma, whose work I have admired for many, many years, and the efforts he had made to introduce genetics in India and the leadership role he has demonstrated. And Madhuri was very helpful in getting all this organized, so I'm going to let her have the privilege of introducing a very strong man who we all admire.
It is my pleasure and really honor to introduce Dr. Verma. Anyone who has done genetics in India knows Dr. Verma. I personally grew up with looking at him as the guy for genetics, and my interest in genetics developed from there. So just as an introduction, he has a very long CV, but I put something together. Dr. Verma is currently the director of Center of Medical Genetics at Sir Gangaram Hospital in Delhi. And this center actually offers the most comprehensive genetic counseling and testing program for biochemical, molecular, and cytogenetics. He was earlier the professor of pediatrics and genetics at the All India Institute of Medical Sciences in New Delhi. He trained in genetics at the Mass General Hospital in Boston, the Deafness Institute at NIH, Willing Lab in Manchester, Guy's Hospital, London, Weatherall Institute for Molecular Medicine at Oxford, and in the Department of Genetics at Zurich, Switzerland. He is a fellow of Royal College of Physicians, London, American Academy of Pediatrics, National Academy of Medical Sciences in India, and Indian Academy of Pediatrics. He is currently the president of the Indian Society of Inborn Errors of Metabolism and the Society of Fetal Medicine. He has also had numerous awards, some of them being the Ranbaxy Science Award, the Indian Council of Medical Research Award, National Academy of Medical Sciences Award, and the B.C. Roy Medical Council of India Award. He is the advisor, he has been the advisor for WHO Geneva for the past 2 decades, and also the regional office of WHO in Southeast Asia. So with that, I will hand it over to Dr. Verma to give his talk.
Well, friends and colleagues, it's a great pleasure for me to be here. And I would to begin by thanking Dr. Madhuri Hegde and Dr. Rani Singh for giving me this opportunity to come and share some of the exciting world of genetics in India. So I'd like to start with this, this voyage with this ship, which is one of the most, or in fact the most famous ship in medical history. That is HMS Beagle in 1838, when Darwin set around the world and then postulated his the greatest thought in the world, the evolution, based on the changes in DNA. So India, friends, is a land of contrast. So on the one hand, you have the bullock carts, and on the other hand, you have these vehicles going to space. So we sent a vehicle to the moon, and in fact, it brought the first evidence that there is water on the moon. In genetics, I remember the O.S. Reddy was one of the very early geneticists in India. He set up the first institute of genetics, and in 1968, I remember he wrote that in India, there are only humans and no genetics. But I think we've changed, come up a long way, and last year we started a National Institute of Biomedical Genomics, which in fact is taking part in the International Cancer Genome Project. I think they are doing next generation sequencing of oral cancer. So this is a news item from the Hindu, one of the prominent Indian newspapers, in January this year. So WHO removed India from the list of polio endemic countries, as no case of polio has been reported since January 2011. And Bill Gates, of course, praised India for this, because only 3 years ago, India had more polio cases than any other country in the world. So I think this has sort of demonstrated the will, that if the will is there, we can do it in India. So contrary to popular belief, genetic disorders are actually more common in India than in Western countries. Because people used to think, oh, developing countries, there are no genetic disorders. So of course, what has happened recently is that infant mortality has come down, and the better ICU facilities. So these infants with metabolic disease, with genetic disorders, they are surviving. Earlier they used to die. And so then we have a greater consanguineous marriages. So what you find in India, of course, we are not as the frequency of consanguineous marriage, not as much as the Middle East. But still in South India, there are 30% of people would preferentially marry consanguineously. While the Muslims in India is the second largest Muslim country in the world, and the Muslims all over India, the frequency of consanguineous marriages is almost like the Middle East. Then there is also the hemoglobinopathies in India. So again, you will find India that very the frequency of birth with hemoglobin disorders is something like 1 in 2,000 births. So it's still one of the very high ones. So based on these factors, because the incidence of genetic disorders is high. And if I show you the burden, okay. So the burden of genetic disease in India is a large population, 27 million births per year. It's a huge number. So you find the congenital malformations, almost 1 in 50, 678,000. Down syndrome, 34,000 cases of Down syndrome born every year. Metabolic disorders, 22,000 cases of metabolic disorders. Beta thalassemia, 16,000, congenital hyperthyroidism, Duchenne muscular dystrophy. So you find all these disorders occur there, and the total frequency is really very high. The largest number of affected infants per year with genetic disorders in the world. So the Human Genome Project, I think, changed the attitude towards genetic disorders. The government woke up. And in the initial Human Genome Project, they didn't take much interest. But I think then gradually the realization has come that this has much to offer us. And so the immediate benefit of the Genome Project came in diagnostics, identification of new genes and the GWAS studies, and leading on to molecular tests and the genetic screening and prevention of disease. And I think this is getting stuck again. Why is it getting stuck? What is this? Okay, this is better. Right, you get this here. So in therapeutics, of course, we are still at the level of research, and pharmacogenomics. The personalized medicine. But I think still it's a matter of the future. We've set up a number of pharmacogenomic tests, but the physicians hardly use them. I think to change the practice of physician is not easy, because they are used to prescribing drugs, and now that you say, okay, do this genetic test before you prescribe the drug. So it's very difficult to change that practice. Okay. So basically, to tackle this whole burden, we have to, I think, genetic counseling is the key. And this is a sort of pattern that we see in our own center. And we find that the 40% of our work is concerned with prenatal diagnosis, because no one wants to have an affected child. If they have one affected child, then they're always very concerned that the next child should be normal. And even generally during pregnancy, they're willing to undergo any test to make sure the baby is not affected. Then of course the single gene disorders, the diagnosis and the prenatal diagnosis, because of the molecular revolution. So this number is increasing over the years. So from 3.1%, now it's almost 15% of our patients we see with guide them about this single gene disorder, mental retardation, chromosomal disorders, hemophilia. So what you find in India, of course, we have the wide variety of disorders. So the counselor has to know about so many disorders. It's much wider than many other countries because here, of course, there are few geneticists. So that you really have to know and widen your interest. So in the classic definition of genetic counseling has been that assists the affected individual to understand the nature of the disorder, the prognosis, inheritance. But I think in India now there is an additionally important task that we have to establish the diagnosis and we have to advise about treatment. Traditionally, I remember when I used to train in Boston, we hardly ever gave any advice about treatment. We were interested in risk of recurrences and calculations, but now it's all here. When the patient comes to us, no specific diagnosis has been made. They say, oh, it's a mucopolysaccharidosis, but what is the type? That has not been established. Mental retardation, many cases come. So, when he come, when the mother is already pregnant, they say, okay, I had a child with mental retardation, and she is pregnant, and then she comes to us. So we first establish the diagnosis in the affected child. So here's a typical consultation. So this family, they died at the age of 4 months. So this couple came to me. Their son had died at 4 months, diarrhea, fever, urinary tract infection, liver disease, hepatitis. So I was scratching my head what it might be. So then she told me, on questioning, that this child had severe thrush, and the maternal uncles also had died from thrush and infection. So this changed the whole picture. So I could now look, here it is, it's an X-linked disease, and we suspected that this would be the X-linked form of SCID, and we were able to study this gene and carry out the molecular test, find out the mutation. So we helped to her to have a normal child in the next pregnancy. We tested her sister, and she also turned out to be a carrier. And so we were able to help her also to have a normal child. So in India, when the patient comes for counseling, he's not only the parents and the child. The whole family will come. So this man came with his parents, and this girl came with her parents. And she had a brother who was blind and had mental retardation. So they told me, okay, what might be the risk to her child? So I said, okay, you bring this child and let me have a look. He was now adult, about 25 years, and you bring him and I'll see if I can help. But when he came, the eyes were almost, the eyeballs were totally destroyed. And really I was again struck what I might do. And then after they had gone back, her parents came back to me and said, doctor, we did not tell you the whole story. Because this mother also had a sister who had a similarly affected child, son. Again, this changed the picture. So when I'm for training, see, Mass General, I think might be there was somebody there who would first describe Norris disease. So I had Norris disease in mind. So we were able to carry out mutation studies in him and then found that fortunately she was not a carrier. And so there you are. So this is how in India we have to be very careful because the whole families will come. They'll come in-laws and this. So what we tell them? So one thing we have to try to avoid blame anybody. Because they're saying, okay, your side of the family has brought the disease, and your side of the family has brought the disease. So we have to we had to tread a sort of middle path. And the words we say can be very helpful to them, soothing, and they come very disturbed. So that way I think the counseling is, we have to be very careful about words. In fact, recently the strength of words, I came to realize that I get an annual from a school principal because I treated him as a child once. So there was an article there that there was a blind man sitting there with a bowl. And he had a board there saying, I'm blind, please help. And nobody was really putting any money. So one girl came along and she inverted the board and wrote something. So people started putting money. So at the end of the day, this man wondered, what had this girl written on the board? And what she had written was, It's a fine day, you can see it, I can't. And that changed the whole picture. So I think the words we use in counseling are really very important to help these families. So diagnosed by report control. So here is a family in Lahore. See, Pakistan is full of genetic disease because of the high consanguinities. And there the services in genetics are even poorer than in India. So this couple from Lahore contacted us. They had lost one child with progressive encephalopathy, and this child was normal. And then this girl, seizures at 3 months, difficult to treat, ammonia levels were high, no acidosis or hypoglycemia, but he had alopecia and there was a rash. So that gave us a clue what the diagnosis might be. So this was completely sort of bald head, the hair, there were hardly any hair. So we suspected that this biotin deficiency. And we they sent us filter paper they sent us urine and blood on the filter paper. We were able to do an MSMS study and showed increase in the C5 and there's a multiple carboxyl deficiency. And we then sequenced the gene and we found the mutation for them. And then they did a CVS in Lahore and sent us the DNA and we found the fetus was affected. But then the pregnancy had advanced too much. So fortunately this is a disease which is treatable. And if you treat them right from birth, they would be completely normal. And that's what happened. So they treated this child from birth and the child is growing normally. But recently, about 2 weeks ago, the man contacted us again that his wife is pregnant again. And he still wanted a prenatal. Because still to have someone who doesn't need treatment would be preferable. So here we are now carrying one prenatal for his current pregnancy. So we have to become, I think most of our training in India is a lot of clinical training. Of course, there are less facilities for this laboratory test, or they are there in all the big hospitals. But still, we have to sharpen our clinical acumen. I think greater. We use our clinical acumen much greater than many other countries where there is a more reliance on the laboratory test. So here this boy was sent to us. Mother was pregnant. This boy was mental retardation, coarse facie, depressed nasal breath, short neck, medial flaring eyebrows, poorly inserted tender reflexes. But he also had this skin rash. They had done tests for MPS and found it to be negative. So this gave us a clue that it might be multiple sulfatase deficiency because they have features of MPS, the coarse facie, they have the poorly inserted reflexes, which is the MLD, and the ichthyosis. So this was the diagnosis. So in this we went on to do the enzymes, and we found all the enzymes, all the sulfatases, the three, we tested three, they were all low, and which confirmed our diagnosis. And we were able to sequence the gene and show the mutation. And unfortunately, by the time we found the mutation, and then the family didn't come back for the prenatal. So here's another 2-year-old boy, again from Pakistan, consanguineous marriage, floppy at 3 months, no head control at 6 months, seizures at 7 months. At 18 to 20 months, inability to sit, stand or turning, and at 2 years was bedridden. Generalized spasticity with wrist reflexes, head size of 55. History of similar illness in a child in a distant relative, which had been diagnosed in England as Alexander disease. But we asked them to send us the MRIs. So MRIs are of course very useful in all the children with neurodegenerative problems. And this will give you a lot of clues. So we here were able to make the diagnosis from the MRI. Because the changes here in the thalamus, the globus pallidus and thalamus were involved, while the putamen and they were spared. And so here, and then of course there's a leukodystrophy, so we made a diagnosis of Canavan disease. So we did the GCMS and showed increased acetyl aspartate, and the MRS was done, and we again find the mutations. And so we were then in that way, so we had 2 more families of Canavan disease in India, and which we were able to do mutation studies and help these families. Now this one disease, which is common in India than anywhere else in the world, this we call the megalencephalic leukodystrophy with cyst, mild course and named after Vander Knapp. This was first described by actually Dr. Singhal from Bombay, in Bombay Hospital. But it got named after Vander Knapp. She was more famous, and which is a phenomenon, of course, not uncommon in medicine, that somebody else first described and gets named after another person. So here is a feature. They come with large heads, and they have some developmental delay. They often get seizures by 1 to 2 years, and then after 3-4 years they may have neuroregression. But many have a very mild course. They go to school, about 50% go to school, and some are even professionals. But the MRIs, of course, are characteristic. So you find there is a dysmyelination throughout, and you find the gyral, they become very wide. And if you do the MRIs, you find this white matter changes all over intensity. And this, of course, that there are cysts in the frontal lobes as well as the temporal lobes. So these are characteristics. So here, gene exon MLC1 gene has 12 exons. So in this, most of the Indian patients which occur in Agarwal's, they have one mutation called the C135. There is an insertion of C at codon 135. And so we have 105 cases we have studied, 43 with homozygous mutation. All the non-Agarwals have a different mutation. But this occurs in both. And it's of course described all over the world, from Turkey and other countries. So in the non-Agarwal, the mutations are different, but in the Agarwal, this is a mutation, and we think this is a founder mutation in the Agarwals. So these are the genetics of MLC1, about 75%, and then new gene has recently been described, HEPACAM gene, and which is about 20% of these. And interestingly, this gene, if you occur biallelic mutations, they will give you like a classical megalencephaly. But if only one allele is changed, then it may give you microcephaly, which improves. Or it is also associated with mental retardation and autism. So we are now ourselves doing a study in the carriers of this gene, whether they are showing any psychiatric changes. Dr. Brahmachari had described about a few years earlier that this gene was involved in schizophrenia. So the Agarwals is a very interesting community that their origin in North India, this in a state called Haryana, and almost 5,000 years ago. And this king had, he had about 17 children, and they had 17 sects. These among Agarwals. So all the Mittal, the rich Mittals, and billionaires. So they are very acute, sharp businessmen, and they have spread all over the world. But they, I think something like the Jews, they have a number of mutations which are they occur more commonly in the Agarwal. For example, they have a spinocerebellar ataxia, and in all Agarwals it's usually the SCA12. They have elevated Spatz disease and a common mutation called the insertion of A in at 215 codon. And they have hereditary factors. We have had two children with Agarwal, and they all have both have the same mutation. So I think these 5-6 diseases we think are founder mutations for this community. And we are developing a sort of panel like the Ashkenazi Jews panel to screen these communities. So here's another child. This child was retarded, and the mother was pregnant, and the history was that the child had delayed milestones, no seizures, severe hypertonia, and increased deep tendon reflexes. He had been intensively investigated. SMA, there was no deletion, EMGs were done, muscle biopsies, karyotypes, fragile leg screening, arise sulfatase were all normal. Here we got the clue again for the MRI. So the MRI showed again that the thalamus and the globus pallidus were involved while the putamen were spared. And you look here in this view, you will find these empty spaces. These are due to the cerebral edema and the increase of the perivascular spaces. And then of course if you look here, the white matter changes, they're sort of linear pattern. So these are classical for MSUD. So we made a diagnosis MSUD, and we were able to make a perinatal diagnosis and help this child. So this child really has done very well on giving him an MSUD diet, although started at the age of 4 years. So probably he had a milder mutation to begin with, because many of them would die in neonatal period. Like here he survived, but at 4 years he was of course retarded. So the parents are very happy with the therapy. So then of course we concern. The chromosomal disorders, just moving on to chromosomal disorders. So these chromosomal disorders, there are many laboratories in India doing the chromosomal disorders. And traditionally these people started doing chromosomal disorders in the departments of anatomy in the medical schools. So we ourselves do a lot of 15,000 chromosomal various developmental delay and amenorrheas, recurrent miscarriages. And then of course the amniotic fluid we done about 7,000 and the microdeletions. So in the US and even the Europe, people are saying that okay, if you have a child, a small freak child, go ahead and do a microarray. And microarrays seem to be sort of replacing the regular cytogenetic. But I think in our country, because of cost, we still I think have to do first the chromosomal study. Because the chromosomal study, the cost is much less. While chromosomal may cost you $60, while the microarray will cost you almost let's say $300. So this is here, for example, we were able to detect on the even on the cytogenetic study that this child had an extra material on chromosome 1, and the father was a carrier with deletion from 11 and going on to chromosome 1. But for publication, the journal asked us that we must do a microarray. We did a fish study then to demonstrate this, and we also did a microarray to confirm. So in India now microarrays also come in. So in dysmorphic children, but still most of us do first a chromosomal study, and if it's negative, then we go on to do a microarray study. As far as screening for chromosomal disease, because I showed you there's a large number of births with chromosomal disease. So we are following the policy that we should shift the screening to the first trimester rather than doing the triple test in the second trimester. We still do a lot of triple test and quadruple test, but the first trimester, the accuracies are greater and is easier. Even if you just only do the nuchal translucency, it's easier to get in India an ultrasound study. It's cheap, easy. Of course, we have to train the people to record it correctly. But even nuchal translucency alone pick up a rate of Down syndrome is 72.9%. While your triple tests are only 77%, and the quadruple is 72, and they see so here you find. So this, if you do nuchal translucency with the PABI and free beta HCG, your accuracy goes up to almost 90%. So we sort of advocating everywhere that go on to do the first trimester test. So we did a study in our own hospital. We followed what's called contingent screening. So at the first semester we did an NT and a HCG and PAPA and divided the people into 3 groups. You had a high risk group more than 1 in 50, we went ahead and did a coronary Miller sampling. Those who were in the intermediate range, 1 in 50 to 1 in 1500, they were about 10%, here was only 1%. So this 10% we went and did the second trimester screening. And those who are negative again, we didn't do anything, but if those who came positive, we did amniocentesis. And the low risk group, we didn't do anything, no further testing. And in fact, at the end of, then we followed all these people right up to birth. And we found all the screen negative really, all fetuses were normal. And all the screen positive. So we really, by this technique, we picked up all those who were abnormal. So we think this is a good way to go about in India. Obviously, we were fortunate not to miss any, but we can miss some always, you know. So this is a possible model for poor resource countries. And the ultrasound really, as I said, is easier. Ultrasound is more easily available than the genetic test because the biochemical assays are more expensive. So here it has been suggested that why do in the amniotic fluid do only 5 chromosomes? do fish study for aneuploidy for 5 chromosomes, or do a pure PCR for 5 chromosomes, and don't need to do the whole full chromosomes. So we examined this in our own series, and we found out of this 7,287, when we did both karyotypes and fish, we found, of course, 96% were normal on both the techniques. But there were 249 were abnormal, and out of these, all the numerical, of course, the common chromosomes, the 5 chromosomes, were picked up by fish as well as by the cytogenetics. But these structural abnormalities, balanced and the structural unbalanced, they were not picked up by the fish. So you miss out. So that really, I think in the US still the tendency is to do culture in every case. But in Europe, I think mostly culture is done only in selected cases because the state is paying. In England, the state pays. So they have cut down the cost by only doing fish. Obviously, if there is an ultrasound abnormality, you would still do the culture. Or if there is a, what we ourselves do, if there is a family history of mental retardation, if there is a family history of abortions, and if the ultrasound shows abnormality, then we will do advice culture along with the fish study or the pure PCR. But if it's a maternal age, advanced maternal age, and all these other things are normal, we just might do this because to save the cost. So biochemical technology has changed. So I think with this TMS, the gas chromatography, all these now are have become available in a number of laboratories in India. And so he was a case was diagnosed as adenosuccinylcyuria, and with treatment he did well. He improved a lot, but certainly since a diagnosis is established late, he ended up with mental retardation. So that's of course is the need to do. So here we do prenatal diagnosis. Many of the so the common in about metabolism, maybe you can get an idea from here. The urea cycle disorders are common. MSU2 is common. The acidemias are common. Epileptosemia is common. PKU is not so common, and some of the other disorders. So the lysosomal disorders, of course, common, and you find the MTS as a group is very common. The largest number we did prenatal, and Gaucher disease and MLDs are common, and I think the GM1 gangliosidosis. So we find that they're doing prenatal diagnosis on the enzyme assays. We have found this somewhat unreliable because the overlap between the normal and the carriers and the affected. So we really the gold standard is the molecular. So we've set up molecular tests for a large number of these inborn metabolism, which we commonly come across in India. And we perhaps our next step is to do a next generation sequencing for these genes and to put them all together. So the newborn screening in India, there was a study carried out in Bangalore, a pilot study, which they screened 100,000 newborns. And they did for amino acids, and they found 4 amino acid disorders were common. But then there was no interest. But in the last few years, as the infant mortality has come down, there has been a renewed interest. And about 3 years ago, the Indian Council of Medical Research funded a study to study 100,000 newborns in different states of India. So 6 centers were selected, and they have just completed the studies. And the results were that congenital hypothyroidism was about 1 into 200,500. So which is somewhat more that you will find in the West. There is a bit of iodine deficiency in India. So that I think increases the frequency of this congenital hypothyroidism. And the CAH also is more common. And so what happens is now a number of states, these small states, they have started mandatory screening. And then of course some pilot projects have started in Tamil Nadu and Maharashtra. And most private hospitals are offering the newborn screening, but at cost. So they charge some money, which is subsidized. And the TMS is available in many centers. So the metabolic screening are taking off now, because these are treatable. So that's the advantage. It's very easy to sell to diagnose treatable disorders. When the genetics, what has held back genetics in India is that people have the impression they're not treatable. Of course, the burden on the people is there. And they fail to realize, some of these politicians, that if you have a child with genetic disease, how tough it is for the family. So they need counseling and they need advice. So the treatment, of course, the special diets now, many of these companies, we could always get these on a case basis. But the companies also have now started getting interested and trying to make some local depots to get the special. And the Genzyme company, fortunately, they started a compassionate program in India where they are giving free treatment. These enzymes are so expensive. In your country, you are lucky that the insurance companies cover this. The insurance companies in India will not repay anything for a disease which is congenital, which means all genetic disorders. So I've been now sort of moving around trying to find ways how to influence and change the insurance policies so that at least the genetic disease get covered. And so now, interestingly, of course, you have getting the trials for exon skipping and Fragile X and SMA, but unfortunately, again, these companies, we get a lot of inquiries from the companies here, that, okay, we want to start Fragile X, to test the drug, but eventually they somehow don't exclude us. But I think there is a big need because there are a lot of patients are there with Fragile X, with the SMA and all these, which can be DMD, there's plenty of cases. And we sort of classified them how many other exons are deleted and whatnot. So hopefully when this treatment comes, it will be very useful for our country. So the molecular diagnosis, I think, all over the world, as you know, Madhuri is here and she set up this fantastic lab which offers such a large number of tests. But we again see the thalassemia is our commonest disorder. Duchenne muscular dystrophy, the next one we do. Fragile X, spinal muscular atrophy, cystic fibrosis also is there in India. And we find that the delta 508 is about 40 to 50%. And the rest of the mutations are different from the panel that you have here. So this panel is very not useful in our country. Only useful, of course, is the delta 508. If it's not there, then we literally have to sequence the gene to find the second mutation. Then, of course, the Prader-Willi syndrome, Angelman, spinocerebellar ataxias, hemophilia, myocardial dystrophy, Wilson disease. So the beta thalassemia, we realized very early that to set up a prenatal diagnostic program, we would have to find the mutation in our country. So we know there is enough data that we know all over India that which mutations are common in which part of India. So here is sort of the Gujarat and Punjab. And so there are 5 mutations which account for about 90% of the cases. So this, of course, has given us the basis of starting a prenatal diagnosis. We ourselves have carried out prenatal diagnosis about 2,500, and now it's available in Delhi and Vellore, in Chandigarh, Hyderabad, in Mumbai. And so we ourselves use 2 techniques to confirm whether disease is not there or there. And we do, of course, earlier we used to do these common mutations, uncommon mutation. So now we just do the common one. If we don't find it, we just go and sequence the gene. Because it's a small gene, only 1200 kb. Albinism is a problem for us. See, it's not considered too much of a burden here. But in our country, we did a study of examining birth defects, about 100,000. And we found 7 out of 94,000 births had albinism. So 1 in 3, so the gene frequency was 1 in 58. And this is very commonly so. And here, because a child with albinism stands out, and the eye problems are quite severe. They can't focus, the eyes keep moving, and so it is a burden. So the people do want prenatal diagnosis. So in fact, of course, there is a common mutation in the tyrosine gene, R278X, which is present in about 50%, and the rest we have to sequence. Fortunately, the gene is not very big, the tyrosine gene. But here was a case where had some darker hair, he had some color, but still he was fairer, which has not come out in this picture so well. But then we have to really study the P gene, the OCA2 and the OCA3, and here we found a mutation in the OCA3 gene. So here was another child, again there was some color in the hair, and here we found the defect in the P gene. So this is an important disease for us, Wilson disease. When I trained in clinical pediatrics in England, and we had a very famous physician who used to say, never miss a treatable disease. It's criminal for a physician to miss a treatable disease, and Wilson disease is one. So I always teach my students, if a child with Wilson disease dies, it's a failure of medicine. But interestingly, at the molecular level, our mutations are quite different from the Caucasian mutations. So this common Caucasian mutation, H1069, does not occur at all in India. So although Indians are Caucasians, so I don't know, this needs study. Although we are considered more Caucasians, and we have cystic fibrosis and many of the disorders, and some mutations are same, but here the mutations are quite different. So why it happened with resistant disease, I don't know. So how the molecular diagnosis has expanded the utility of genetic counseling is illustrated by this case. So this 8-year-old boy is a healthy school-going incidental seizure in the class. Generalized or brief on examination was completely normal except mildly brisk deep tendon reflexes. But the MRI again gave us a clue. So this was done in MRI and you found these white matter changes in the occipital area. And this told us that this adrenoleukodystrophy. So we confirmed it on doing the VLCFAs, which were characteristic of this one, and we did the gene studies. Now, interestingly, they did actually matching for the family to try to find a match for a bone marrow transplant. And this is what we found. So when we did this, so they were doing actually studies on these other siblings, and we found this sister, she was a carrier, the sister was also a carrier, and she had a son who had no symptoms, was completely healthy, but he also was positive for the mutation. So the issue was no, it was difficult to convince this family that there is something wrong with this boy. Well, he was perfectly normal. But when we did his MRI, we could still see very early changes, although he was asymptomatic. So here the ideal situation for him is to do a bone marrow transplant. But the availability of a matched donor, so that's the limiting factor. And in India there is a cord blood storage is going on, but it's all on the private sector. So we do not have a public sort of system because we have 27 million births. If you just collected their cord, the stem cell, it will be an amazing resource. But somehow the money involved perhaps is holding back the government. So the number of private banks are there, cord blood banks, and some of them we are able to get a very close match. Fortunately, in the cord blood, you can do a little bit of mismatch and the cord blood stem cell can get accepted. So the cousin was diagnosed with the disease before his symptoms, and the bone marrow would have been curated. So as I mentioned earlier, pre-early diagnosis is greatly in demand, and we ourselves are, with the help of Perkin-Hammer, we have set up the backs on beads technology. And the microarrays are coming, but we're not yet available as a routine. And we are also working on the non-invasive prenatal diagnosis, which would be very useful. I think now, I don't know how common it has become in Europe, in US, because it's there now, the Down syndrome, you can do a non-invasive screening. So maybe some of these, the triple tests and all might go out of the fashion. But this is another important thing because many of these families with this genetic disorder, they keep on having affected children. So they want something to bypass that, to go through the agony of a prenatal test and affected child and repeating this again the next one. So there is a demand for the pre-implantation. And I think we are working on this, but we haven't yet got, there is some pre-implantation diagnosis available, but only for chromosomal disorders, the aneuploidies, not for the single gene disorder. So we, of course, the molecular techniques using this. As I mentioned earlier, thalassemia is the largest, and then all these other intrauterine infections also is a problem. They will use the molecular technology to diagnose whether the fetus has the disease or not. So as I said, we are developing our own panel that we should screen every pregnant woman and to reduce the burden of these disorders. Thalassemia, spinal muscular atrophy, Fragile X, Duchenne, phenylketonuria hyperplasia. So these we find some of the commoner mutations in our country. Country is full of new syndromes, if we had the technology. But this one we were able to find that here was a child with spasticity and had the skin changes. And you know, once you find this, there's one disease you think of, these are skin changes like ichthyosis, you think of the Sjogren-Larsen syndrome. So we have been working with Bill Rizzo in the US, and we sent him the skin fibroblasts, and he found the change in the gene, and he demonstrated this. But here was a case, had a similar picture, had spasticity, extension, had the skin lesions, had microcephaly with changes in the brain, cortical atrophy, but the SFS, Journal Nonsense Syndrome, was excluded. So we had some family in India, and there was one family in Saudi Arabia. So the exome sequencing was done for these two families. And of course, using applying these filters and excluding these markers, so you will end up with 3 genes which could be involved. And then these were sequenced by Sanger sequencing. No mutations were found in this one, but in the second one, mutations were found, homozygous mutations. So this confirmed as a new gene. So this gene has involved in some eye disorders, the Stargardt syndrome. But this was the first time when it caused this disease also. So there's a lot of interaction of these genes. So this exome sequencing, I'm sure, in the years to come is going to reveal a lot of new genes and new interactions of the various genes. So in India, before we marry, we use this. We match the horoscopes. So whether in the future, so people have been saying that match the genes. And this was a prospective couple might look at their DNA studies and get the markers on the computer and examine them. So I don't know whether it will be a good thing. Personally, I think it will be a bad day when we start matching this DNA before you marry. Because everyone is carrying these abnormal genes. So this is my last slide. Of course, we have the nucleotides. This is the genomic paradigm in all over the world. You have the nucleotides making genes, you have the genes making RNA, you have the RNA making protein, and you have the protein making money. Well, friends, thank you.
Any questions or comments?
So I had one comment.
Yes.
Your slide on the Agrawal community and
Yes.
the common mutations. So we have just identified a founder mutation in the calpain-3 gene.
Okay, in the
So we just submitted
Calpain.
the paper.
Oh, very
Calpain,
nice,
We have submitted the paper to Muscle and Nerve, and this was with Dr. Khadilkar. He
Right.
had 9 unrelated patients in the
Yeah.
Agrawal community.
same mutation.
Same mutation. We found 3 mutations, homozygous, heterozygous state.
Yes.
But I didn't know, I was not aware that there were all these other
So many others,
mutations,
yeah, this is what we were
Agrawal
searching.
community.
And I think this might be true for many ethnic groups in India. And I think it needs careful study. Because the ethnic groups, they don't marry consanguineously. In the Hindu religion, they said 6 generations behind, you should not be related. But the community is the same. So they will marry within the community. A Sood will marry a Sood, although not directly related. And I think the Agrawal, they don't marry consanguineously. But you have this founder mutation. So I think it's a very fertile area for research.
I'd like to know how you get the microarrays done for $300. Do you have a company that works with you?
Yeah, well, there are a number of companies, private companies, set up microarrays. And so we send it to them. We ourselves are in the process of establishing our own institute. And but I find, see, in India, money is not short. To buy a microarray system is very easy to establish. And there is money in the sense, each test is going to cost, so you can make money easily. So the private labs, like you have Quest and LabCorp, the Quest is in India also. And I think they are also now thinking whether to start microarrays. I know the biochemical man, Rajesh Sharma, who is their head, he actually worked with me for some time in India. And so they are now thinking of bringing TMS also, but TMS already exists in many laboratories. Microarrays also, there are a number of laboratories. And the technology is coming cheaper. So I think most of the big centers will start offering these microarrays. Because these parents, they have an abnormal child, they want to know why it happened. Just do chromosome, you won't find anything. So, but here if you tell them, of course it brings its own problem. You have to study the parent, did it come from one of the parents and all that. But still, it is some internal satisfaction that okay, it was not their fault, it's just the change in the DNA which occurred. Yes, you had a question.
Well, you mentioned how difficult it is for the Gateses of the world to actually understand that what they've done with infectious diseases, if they look at the next 20 years, they need to be setting up to do the genetic and the birth defects and the developmental disability things. But now, just all being lumped into kids dying or people not
Yes.
seeing them and so on. How do you change that conversation? Are you having any luck changing that conversation?
Okay, the change has occurred, that the shift has already occurred in the non-communicable diseases. The government is investing huge amounts, but what they include in non-communicable disease is diabetes, hypertension, epilepsy, cancer. We have a plan called the National Rural Health Mission, which has a budget of more than the Ministry of Health. Because the idea is to establish all these facilities and take them to the rural areas, which is a very nice, of course, it's good and it's working. So the minister said, let us, and non-communicable diseases are rising because of the food habits, and not less exercise and eating more. So diabetes really, India is supposed to be a diabetic capital of the world. There's so many diabetes. So they said that he has sanctioned a plan, 100 districts are screening everyone for blood sugars, for ECG, and to pick up these diseases. So we even try to ask them that give some budget also to the birth defects, to the genetic disorders. And they have said, okay, fine, we will do it. But still, because I think the issue of treatability, see the diabetes you can treat in the sense, okay, you have insulin and you can reduce weight and you reduce your requirement. Genetic disorders still, the treatments are more complex, special diets and all these things. And but the situation is changing, and it will be easy. I think if we present is a package for a healthy newborn, so we can focus on the newborn. Screening can come by focusing. The government is very keen for this healthy newborn. And for example, this I know Simon Godfrey is an old friend because of the folic acid fortification. So there is no, in fact, there is a lot of interest in fortifying food with folic acid to try to reduce the neural defects. And so I think things are changing. And yes, please.
So you mentioned a number of metabolism disorders that, here at least, probably a good number of those would have been picked up on our newborn screening. And I was wondering, what is the status of newborn screening in India?
Okay, it's not yet mandatory. It's not the government has no plan to start in everyone, because I think their still focus is to institutionalize all the deliveries, because the maternal mortality is still high in India. So their focus is bring all women to deliver in some institution, which will cut down the maternal mortality. And there is a lot of focus on the newborn. I think they are not that. I think we as United States, we have to do a lot of campaigning to make them, convince them that this is required and this is useful. I think the hypothyroidism they would be very willing to accept, because easy to treat and easy to test. And once it's set for hypothyroidism, then I think we can go on to the other diseases. I think we cannot jump straight away to the expanded newborn screening.
But you do screen for like PKU, I'm
Yes.
assuming.
PKU is less common in North India. See, like 1 in 15, 20,000. So we ourselves in our hospital, we offer screening for 3 disorders: hypothyroidism, congenital adrenal hyperplasia, and GCPD deficiency. And the rest we sort of leave on to testing a symptomatic check, because the PKU is so 1 in 20,000. So, but I think if we offer, people will take it. But we are charging at a very subsidized rate from the parents. So all deliveries in our hospital. So maybe we should expand. That is, our neonatologists have been saying, why don't you expand the range and do PKU and galactosemia. Galactosemia is also one of the common ones. MSUD.
Wow, I mean, especially with your rate of consanguinity, I mean,
Yes.
it's sort of like a ripe opportunity.
But there is one catch. Dr. Sanvi was a very famous statistician. He said, consanguinity going over centuries reduces the incidence of genetic disorders. It's not as bad if you marry consanguinity over in 1 generation or 2 generations, because the bad genes get weeded out. You get one affected child, you lose 2 genes. homozygous to recessive gene. So he put this theory and he showed curves that going over 100 years is consanguineous marriage to 2000 years. So you find that the frequency of the disorder becomes less and less. So in fact, in practice, consanguinity does not appear to be harmful. The common man who is marrying consanguinely says, oh, my family are engineers and doctors, and you are saying consanguinity is harmful. Our people have been marrying consanguinely. But if you look at the genetic clinics, there the consanguinity is associated with the problems. But if you look at the public, you find a large number of consanguineous marriages, no child affected child. Although it's in Arab countries, really situation is bad, because there, of course, they have many children, and so but now I think the Arab world also has got woken up to the fact, and they have in fact mandatory screening for genetic disease. So in Dubai, the Abu Dhabi, Saudi Arabia, they have a mandatory screening for genetic disease before marriage. Of course, they focus on before marriage because they are slowly changing that prenatal diagnosis should be allowed. But so far, many of the Muslim countries, prenatal diagnosis not allowed. But once you face, say, Pakistan has allowed the prenatal diagnosis. Dubai has allowed. Tunisia, there's a number of countries, Iran. See, Iran had such a huge problem. I don't know what percentage of the national budget was going into treating thalassemia. So they woke up and said, well, this is a thing we should control. So they started doing pre-counseling, the pre-marriage counseling. But they found 50% they are related to you. So that sort of is a very interesting.
So the arranged marriages are still very high in India, right?
Yes, I think it's changing. It's in the cities mostly of the people just sort of find their own mate but the villages, I think, still not of arranged marriages go on. But you know what Socrates said, that you find a good spouse, you will be happy. And you found a bad one, you will become a philosopher.
I was just going to ask, it sounds like there's a lot of opportunities for genetic counselors in India. Do you know of any training programs, or are they planning to develop?
Okay, there are no training programs yet for genetic counselors. So I was talking to Madhuri and wondered that we should start one. I think because we watching what the genetic counselors are doing here, it's a tremendous job.
Right.
And they said reduces the burden for the clinical geneticists. And so I think there is a need. The youngsters, the MSc graduates, and they are very keen on genetics because see, the newspapers are full of these genetics, so they get excited. And so I think there should be, and a lot of them come to US to get MSc in genetic counseling. They go to England for MSc in genetic counseling. So I think there will be a need, and there will be a good take, and they will be useful.